Good afternoon, good evening. Thank you for joining us for the weekly briefing from Africa CDC. My name is Margaret, Edwin, the Director of Communications. I will be moderating this session. The weekly briefing touches on health emergencies across the continent, and today we are joined by Dr. Ngashi Ngongo, the head of the Incident Management Support Team based out of DRC. Dr. Ngashi is also the Chief Advisor of the Director General of Africa CDC. I will now hand it over to Dr. Ngashi to start the session. Over to you, Dr. Ngashi.
Thank you very much, Director. Good morning, good afternoon, everyone, depending on which part of the world you are in. We are delighted to have you again for this week's press briefing, just to update you on the situation and the management of public health emergencies on the continent. In the main, we still are experiencing the expansion of the Mpox outbreak to new countries. Even great concern that big countries like Ethiopia have now reported cases as well, both in East Africa of Ethiopia and West Africa of Togo. But at the same time, the continent is still experiencing multiple outbreaks. I think cholera has now reached 20 countries, and we are planning a high-level meeting of the head of state that is planned for next week. I think those are some of the main highlights that we are going to take you through this presentation. I think with those few words, Director, we can open the presentation. Now let's move on to the next slide. Yeah, let's first start with just last week's event. The VG led a team of Africa CDC to the World Health Assembly in Geneva. There were very interesting developments of the organization. We just want to mention a few. Africa CDC signed an MOU with the Texas Children's Hospital in the US to collaborate on the fight against childhood non-communicable diseases, with a focus on sickle cell disease, which is a disease that affects about 12 countries on the continent, and a very important one, on our agenda on disease control and prevention. That collaboration is including a joint adventure to develop vaccines, but also a research fellowship and some digital tools that will be developed, as well as a focus on really creating the market for different measures to fight sickle, to prevent and also take care of the sickle cell disease. And just to say that this is the kind of partnership this is fully aligned with the Africa CDC strategic plan. And we are delighted to see more partners coming to support our public health agenda on the continent. Next. We also had a number of interactions really to advance the health financing agenda to link to what is happening globally, but also being concerned with our continent of Africa. As you know, it's about $8 billion that Africa is going to lose through all the cuts that have been announced. I think they did this time also consulting with some of the global personalities like Peter Piot, but also even our political leadership, with some of the ministers of health, including the Minister of Health of Morocco, His Excellency Amin Teriawi, where the discussion also focused on how we can boost our public health agenda, but in a way that can also contributing to addressing some of the financing gaps that have been left through this financing crisis. Next. They did also meet with important partners, including the Executive Director of UNAIDS, Mrs. Winnie Denima, there to discuss how we can really move on our cooperative agreement for advancing the HIV agenda. As you know, that's one of the programs that is most affected with what is going on right now. And also, in addition to that, we also met with the Health Secretary of Norway to advance our collaboration, which includes even the discussion we have now to also build up a much stronger DHIS2 on the continent, which can respond both to our agenda on universal health coverage, but also on the health security. Next. Now, coming to the public health event, what we've seen is the growing number of public health events. Just looking at the high risk and moderate risk events that have been reported over the first 5 months of the year. Last year, we accounted for 124 over the same period, and this year we are now at 129. Just to say that we are slightly on the upward trend. And look at the high risk, that's about 54 of them against 40 last year. But the moderate risks are much higher. We have 95 against 84. And the 5 most top outbreaks that were reported this year include cholera, for which I just mentioned that we are going to be having high-level meetings next week on Monday with the ministers of health, and then on Wednesday with the head of state of the 20 member states that are affected. But in addition to that, we have Mpox that is still active in 19 countries, and we have measles affecting 17 member states. We have dengue in 7 member states, and Lassa fever affecting 4 member states. Next. I started talking about the situation of Mpox on the continent to say that we have reached 139,000 suspected cases since last year, of which almost 35,000 confirmed cases and 1,788 deaths among the suspected cases. That's a case fatality of 1.3%. and 186 deaths among confirmed cases, giving us a case fatality of 0.5%. Now, during the week 20, there were about 2,836 notified cases. That's against 3,286 the week before. We had 999 confirmed cases, also against 1,160 the week before, showing that there has been a decline on both the notified cases and the confirmed cases from week 19 to week 20. But what is interesting to notice is that when we compare the number of cases we had in 2024 and the number in 2025, already now, just 5 months into the year 2025, we've already registered 94% of all the cases confirmed in 2024, and almost 79% of the cases registered as suspected cases in 2024. Just to show that that's just 5 months. By the end of the year, the burden will be much higher, perhaps most likely more than double the burden that we had in 2024. But it is important to notice that there's a new country, that's Ethiopia, that reported cases this year, this week. I will come back to that. And also that Sierra Leone is the one that is contributing the most to the cases that are reported, especially among the confirmed cases. 74% of cases reported on the continent just come from Sierra Leone alone. Next. Now, when you look at the geographical spread, on the left, you see the clades that are in circulation on the continent. The picture that we have now, it's clade 2 circulating in West Africa, clade 1 circulating in Central Africa, both 1A and 1B. With the 2 Congos that have the co-circulation of 1A and 1B, and then clade 1 in Southern Africa. But when you look at the evolution of the outbreak itself, I think we have about, of the 25 countries that are affected, there are 7, I think there are 7, the number here needed to be corrected, 7 that are under control mode, and 18 that are still active. Next. We also looked at the epi curve of different countries. It is very interesting to see that the highest burdened countries, which are DRC and Uganda, are now showing the stabilization of the epidemic, while Burundi, Rwanda, and Nigeria are showing a decline. But we are still really concerned with Sierra Leone, which is really where we see most of the numbers going up, and also the new countries that are now also joining with the cases that have been reported in those countries. But in summary, during the week, the 20th epidemiological week, Sierra Leone and Uganda, just the two of them accounted for 93% of all new confirmed cases. And again, reminding us of the great contribution of Sierra Leone that take alone 74% of all the cases, where our attention as the IMSC need to be focused the most. Next. Looking at Ethiopia, I think there are 3 cases that have been reported in Ethiopia since May 26. And for Epi week 20th, I think that all 3 cases have been confirmed, and there's no deaths yet. Among the confirmed, I think males make 33%, and also children below 15, 1/3. I think in this case, it is an infant that was a 21-day-old infant that was tested, and also with both parents, the father and the mother, that also tested positive from the Moyale town in Oromia region. If you look on the map, that is a region that is really bordering Kenya, and also not very far from Somalia. I think we know that in Kenya, there have been clade 1B that has been circulating. I think most likely it will be 1B that will be identified in that region of Oromia. But also the proximity of Somalia, knowing all the challenges that are in Somalia, make it that we need to be really very bold and aggressive to control this outbreak from the source, so that it doesn't expand further from the Oromia region. But the testing coverage so far is good. We have 100% of all the tests have been collected and tested in the lab, with a testing rate of 100%, meaning that all the 3 cases tested were tested and the results were released. Next. In Togo, the Minister of Health declared the outbreak on the 16th of May. By week 20th, I think there have been 37 cases that were notified, of which 8 were confirmed, no deaths yet, which is really good news. So far, so we don't have data yet on the disaggregation by gender and age. I think we'll share that next week once we get it. But we have confirmation of the clade already in Togo, which is 2B. I think that is very much in line with the clade that is circulating in Sierra Leone and Liberia as well. I think there also we can say that the testing coverage is good, 100%, the testing rate 100%, with the positivity rate at 21.6%. And there are 2 districts that have been affected so far, and the contact tracing is also very well done, with 136 contacts that have been listed, and all of them being followed up. I think we expect an average of about 20 contacts per confirmed case, but if you take that divided by the 8 confirmed cases, it shows that there are about 15 contacts that have been identified, showing that really the surveillance is working in that country. Next. In Malawi, also there have been 122 suspected cases that have been reported, of which 4 have tested positive, and there's no deaths yet. Malawi being in Southern Africa, the clade that have been identified is clade B, and children below 15 years make 10% of all the cases reported, and males 90%. I think there are 3 districts out of the 28 districts of Malawi that have reported cases. Lilongwe, 8 cases, and then Mangochi 1, and Cheo 1. But it is very important when you look on the map to see that though we have especially Lilongwe and Cheo that are bordering Zambia, which means that it clade 1B that is circulating in Zambia. There also in Malawi, we can say that the testing coverage is good, 100%. The testing rate also at 100%. The test positivity rate at 6.9%. And the contact listing also doing very well. 152 contacts, I think, that have been identified out of 12 confirmed cases, meaning that they have more than 10 contacts per confirmed case, which is good. But they are working very hard to push that number to close to 20, and all of them are under follow-up to identify any new case among those that have been exposed. Next. In Sierra Leone, that's where I think most of the cases are now concentrating. There were 648 cases notified during week 20. 603 of them that were confirmed. But when you look at the trend compared to the previous week, we are seeing already a decline of 10 and 8% respectively on the notification and also on the confirmation of cases. And the number of deaths among confirmed, there were 3, I think, that were reported. But looking at the confirmed cases, once again, males are dominating with 68%, and children below 15 years just make 2.7% of all cases. As a typical picture of West Africa is clade 2B that is circulating. And again, the testing coverage in Sierra Leone is very good at 100%, testing rate at 100%, but the test positivity of 88% says something about the surveillance, which definitely is here. It's passive surveillance that is prevailing in Sierra Leone until now. Now, all the 16 districts are actively affected right now, are all active, but there are 3 that account for 91% of all causes. That is the western area urban, the western area rural, and also Bombali. And in total, 1,641 cases that are still active out of the 2.6 thousand that have been identified so far. I think some of the main weaknesses so far, it is the surveillance that has remained passive. I think that need to be also strengthened. They had an initiative called Find Them All, which has stopped. I think it needs to be urgently reactivated to be able to switch toward active surveillance. And then the second major challenge was on isolation capacity. Although the situation is improving now, at the time they had only 60 beds. Now we can see with the 1,600 active cases that are there, but that capacity has increased to more than 400 right now, showing that the response is now starting to show some positive result on the key challenges faced by the country. Next. Now, in Sierra Leone, I think the support has been in different areas, in the area of vaccination, in the area of surveillance, in the area of laboratory, in the area of IPC. But on IPC in particular, we have been able to conduct a rapid assessment of IPC in the health facilities to identify the areas that need urgent support. We've also provided the IPC supplies, and we are currently working on building the capacity of healthcare workers as well as community health workers to ensure that they have not only the skills but also all the supply they need to contribute to preventing the spread of the disease. Next. Now, in the DRC, that's where the epicenter of the outbreak has been since the beginning, with the highest numbers of cases reported. Since last year, it's now 105,000 cases reported, almost 21,000 confirmed, and 110 deaths that have been reported so far among confirmed cases, giving a case fatality of 0.54%. But for the week 20, 1,748 cases were reported against 2,021 the week before. On the confirmed cases, 182 that were reported compared with 217 the week before, showing that on both the notified cases and the confirmed cases, we are also seeing the declining trend, where I was talking about the stabilization. And if you look at the epi curve of DRC, you notice that over the last 4 weeks, there is a steady decline. I think that has been maintained. That gives hope that all the measures put in place for the intensification phase are starting now to yield some good result. Now, of the confirmed cases, as I said, there's co-circulation of clade 1 and B, and that males also make 54%. But children in the DRC below 15 years of age account for 36% of all cases reported. Now, unlike on the other countries where we saw testing coverage at 100%, I think DRC and Nigeria are the two countries where we still see major challenges related to the testing capacity across the country. And also the testing rate is good because all the samples that reach the laboratories are being tested. I think the challenge is mainly before reaching the laboratory, meaning at the level of the investigation, to ensure that all the cases that have been notified and confirmed are sample collected and that the samples are transported and dropped in the laboratories. I think that's the area where DRC is facing most of its challenge. The test positivity is now at 38%, and there are about 1,810 cases that are active right now. Just to say that the DRC is reviewing its data. They are doing data harmonization on suspected cases, which means that that might also influence even the numbers that we have reported today when we come back to you next week. But it's also important to say here that the situation in the Kivu, where there have been the ongoing conflict in the eastern DRC, has really stabilized. Vaccination is back. Most of the activities are ongoing. We've been able to even deploy epidemiologists. And right now, I think we're in the process of also recruiting community health workers, training them and deploying them to strengthen the surveillance, especially active surveillance and contact tracing. Also to say that there are 6 provinces in DRC, that's North Kivu, Kinshasa, Sud Kivu, Tanganyika, Chopper, and Equateur, that account for 97.5% of all cases. I think that's what the really focus of the intensification effort are concentrated in those 6 provinces out of the 26 provinces of DRC. Next. The situation in Uganda is also giving some hope, as you can see from the epi curve, that the situation is also stabilizing. In total, 6,324 confirmed cases, of which 42 deaths, with a case fatality rate around 0.6. But during week 20, we had 148 confirmed cases compared with 233 the week before, showing that I think that declining trend is what we are observing now. The reason why we are now talking about the stabilization of the situation in both Uganda and DRC. Now, it is clade 1B that is circulating, and also males make 56% of all the cases that have been reported. Just to say that Uganda accounted for 18% of all confirmed cases during EPI week 20. with a 43% decrease in cases compared to its peak incidence on AP week 11. I think that's really good news. And the decrease of cases shows some light at the end of the tunnel, but the intensification continues and the surveillance also is being strengthened to make sure that over the next 3 months we can maintain the current trend and leading the country to a total control of the outbreak. Next. Now, on the vaccination, I think just one important message to say here that our plan 2.0, covering the period from March 2025 to August, which is the intensification plan, estimated that we needed 6.4 million doses of vaccines to cover the countries that are affected. But the difficult news, if I can say, is that until now, we only have visibility on about 219,000 doses from the US government. Even those doses, they're still awaiting the authorization from the US government to be used. There was another 348,000 doses that's supposed to come from UNICEF, but UNICEF is still working very hard to mobilize funding. That really we are looking for different donors that can also come in, step in, and help fill this funding gap. I think that's the current situation as it is now. But looking at the experience of the countries that have vaccinated so far, the vaccine acceptance has been very high across the continent. We have now more than 700,000 doses that have been administered. DRC accounting for 80% of all the people vaccinated so far. And the good news is that the LC16 is supposed to be arriving, and the training has already started since May 26, starting with Kinshasa province, and then that will also go down to the health zones. Just also to say that in the DRC, children 0 to 1 to 17 years have been included in the vaccination, and already they account for 22% of all the people that have been vaccinated so far. I think that is good progress. We are working with other countries to also include the vaccination of children below the age of 18. Next. Yes, vaccination still there to say in total it's about 11 countries that have received vaccines and 7 countries that are vaccinating. That we have Sierra Leone and Zambia with 51,000 doses. That was the TRC recommendation on the 28th of May. But the good news is that we have about 1.5 million doses of LC16 from Japan, and also 100,000 doses of the MVA from France that are supposed to arrive in the DRC today and tomorrow, respectively. I think that's good news for the DRC as the country is moving into the intensification phase. Next. Now, switching from Mpox to cholera, just to say that the situation of cholera is of great concern, that when you look at the trend in the number of cases from 2022 to 2025, we had 104 cases in 22, 224 in 23, 254 in 24. You see, it is the upward trend, and already now, just by May 2025, we have already reached 127,000 cases. That to say that there's great concern on the rapid spread of cholera. There are now 20 member states that have been affected, and we have a case fatality estimated around 2%. But we see that the cases that are reported in 2025, really exceed the cases that were reported before if we continue at this trend. And there are 4 countries that account for 83% of all cases and 92% of all deaths. Those are Angola, DRC, Sudan, and South Sudan. Next. In the DRC in particular, you can look at the epi curve. You see that the situation over the last 2 months has been really increasing. But we see during the last weeks that there is a downward trend. I think that is starting. If you look at week 20, the 1,350 cases that were reported against 1,637 the week before. And also on the days, 31 days also reported against 31 the week before. I think that trend is trying to show a little bit of a decline, but the question is whether that to be sustained over time. Also important to say that children under the age of 15 make 45% of the cases. I think that's why the concern also is about the impact of this cholera outbreak on children. Some of the major drivers of cholera in the DRC include the insecurity that we know already happening in the DRC, the wash infrastructure that is very weak. We heard about the flooding. I think that happened in the DRC because of heavy rains, but also the poor health practices, including the health-seeking behaviors that also contribute to the spread of the cholera. In total, it's about 26,000 cases, I think, that have been reported in 2025, of which 557 deaths. That's an overall case fatality of 2%. But just to say that already 11 provinces out of 26 that have been affected, and we don't know, as the year continues, we need to make sure that really control effort can limit the spread to other provinces. Next. In Angola, also, we have seen the beginning of the stabilization of the situation in week 21 because Angola has got much recent data than DRC, which reports every 2 weeks. In Angola, week 21, there were 1,473 cases compared to 1,479 the week before. There were 55 deaths, I think, against 21 the week before. It meant that there was an increase on the mortality while there was stabilization on the number of cases. But looking at the people that are affected, males make 54% of all cases and 62% of all deaths. But children, again, make up to 39% of all cases and 33% of all deaths. But what is important to say that 60% of these deaths are happening in the hospitals, posing the problem of the quality, the timeliness of care seeking, but also not the quality of care, which are the 2 factors that can really contribute to lowering this mortality. But overall, in the big picture, we see a decline of the number of cases in the last 4 weeks. I think we can see that from the AP curve as well. And just to say that the major drivers are very much similar to what we see in the DRC. Next. Now, there are also other outbreaks, I think, that are being reported on the continent. As I said, I think perhaps we see next week we might want to also include some of them. But today we just wanted to report mainly on the Mpox and also on cholera. We can say that really on the Mpox, the situation is stabilizing in the initial high burden countries, getting out of control in Sierra Leone, where we need to intensify, but also worried about the continued spread in Togo and Ethiopia. But at the same time, on the cholera front, we see that the situation is still of great concern. I think that's the reason why we, both WHO, UNICEF, and Africa CDC, we've worked together to convene the meeting of the continental leadership both the ministers of health on Monday, 2nd of June, and the head of state of the 20 most affected countries on Wednesday, 4th of June, just to look at ways that can really reinforce the current response and move more toward a well-coordinated continental response, which is really multi-sectoral, bringing together not only the Minister of Health this time, knowing the role that the water and sanitation sector also plays. I think that's the reason why that was escalated at that level to really have the buy-in and leadership at country level. The World Health Assembly was an opportunity for us to strengthen our partnership, but also to address one of the major challenges that we are facing now, which is the health financing that has been declining. And then with the recent development, I think declines even more. But it was an opportunity really to ensure that not only us, but also our partners start thinking about finding alternatives to addressing this, but also the strategy of Africa CDC, which is based on three main pillars: on domestic, increasing domestic financing, also putting in place some innovative financing on the continent, and the third pillar about blended finance to also attract the private sector into Africa is very well received. I think it's something that we are continuing to work on. Also, just wanted to say that we have the emergency consultative group meeting, which already met to assess the situation of Mpox on the 22nd of May. I think you should be getting the outcome of that group very soon. We also hear that WHO will be also convening the emergency advisory group of the Director General on June 5th to also look at the situation of Mpox again and make recommendation on how we need to move forward. I think with that, Director, I would like to end there and just open up for questions and comments. Over to you.
Thank you, Dr. Ngashi. Let's take the first two questions. We have James Kunda from Anadolu News Agency. The question is, I would like to find out if any other community after Angola made the initial commitment of $5 million. The next question is we have Anna from another news agency. The question is, what are the primary and environmental factors contributing to the recurrent emergency and rapid spread of infectious diseases outbreaks in sub-Saharan Africa? And how can regional health systems address these vulnerabilities? Over to you, Dr. Ngashi, for those first two questions.
Okay, I hope I've heard you, Director. I think your voice was kind of breaking, but the first question might be related to the member state commitment, financial commitment to Africa CDC. Yes. If outside Angola, there's another country that has also contributed, if I heard it. Yes, the answer is yes. We have other countries that have also contributed. Morocco has made a commitment. The DRC has also made a commitment. And the DG is also discussing with the president of South Africa, also on the same, just to say that we have at least 2 million committed from Morocco, 5 million from the DRC. And those contacts continue, especially in the current context where we see development aid declining. It becomes extremely important for the member states to step up, and also fill the financing of our public health institutions. Now, the second question is the factors that contribute to the spread of infectious diseases on the continent and what we can do about it. I think there are a number of factors that contribute. First of all, it is the socioeconomic life of Africans, which explain this continued contact between humans and animals. As you know, there are places that really animals constitute the main source of food for communities, making it then also maintain that risk of the transfer of zoonotic diseases from the animal world into the human world. In addition to that, we also know the effect of climate change. I think the ecosystem that is changing, becoming more favorable to some of the pathogens in areas that they were not accustomed to in the past. We know the major weaknesses related to the health system itself, which also explain why some of the diseases, when they get into the health system, they get into hospitals, then hospitals become the source of transmission and spread of those infectious diseases. We've had enough evidence on Ebola, all those other diseases, because the infection prevention and control measures, for example, are so weak in many of our facilities, reflecting the overall weakness of the health system. We have also elements related to the low financing, of our health services. As you know, you need to invest more in health to build a robust system that can really resist shocks like outbreaks that are related to infectious diseases. And finally, the issue of insecurity in many areas also is also contributing to the spread of diseases. Just to give you an example, during Mpox, when the fighting went into DRC, even people that were already isolated, confirmed positive isolated, all of them ran away from the treatment centers and then went back into the community. I think all those are factors that contribute not only to the spread, but also to the inability for us to respond adequately. On many of those, I think Africa CDC is working with many partners to address that. We are working with the Global Climate Fund right now to also mount a very important program to address the consequences of climate change on health. We working on the health financing. I think I just briefed about the strategy that we have developed that has been presented to our member state, to our president, and also to the international partners to disseminate how we like to increase actually the financing of health to be able to build stronger health systems. We have also an entire program here at Africa CDC, which aims at strengthening our health systems in different areas that are essential for the prevention and also response to infectious diseases, but also including even infectious disease outbreaks, like the pathogen genomic that we have on the laboratory that looks at really decentralizing, accelerating access to laboratory diagnostic capacity and also the pathogen sequencing capacity. We are working on that. We are working on surveillance through community-based surveillance to make sure that our country do have systems that allow them to identify these infectious diseases on time and act on time. And finally, I think I can also mention our work around local manufacturing, which is also important because we are pushing through that to build the capacity on the continent to be able to produce the different medical countermeasures that are important for prevention, be it vaccines, for diagnostic with tests, also for treatment, develop them on the continent to be able to also support our efforts to prevent and response to pandemic. I'll stop there, Director.
Thank you, Dr. Ngashi. Let's take the next two questions. We have Michael Guarisa from Health Times Zimbabwe. The question is, given the vaccine dose gap you mentioned, what measures are being taken at the continental level to procure vaccines beyond support from UNICEF and the United States? The next question is, did you hear me?
Yes.
Okay. The next question comes from Lucia Blanco of the Spain International News Agency. The question is Africa's CDC doing something to respond to the crisis on the ground? And what challenges are you finding on the ground so far? Over to you, Dr. Ngashi.
Okay, I think the question about crisis on the ground, we are talking about outbreaks, right? If I understand well.
Yes, it's a cholera outbreak in Sudan.
Okay. Now, let me start with the first question about what we are doing. We are doing to mobilize, to procure more vaccines beyond UNICEF. I'll start first by saying that Mpox vaccines are quite expensive vaccines. One dose is costing $65. And most of the doses that we have received were donation in kind from Western countries. I think most of the doses. And then we also have the contribution from Gavi and the contribution from UNICEF that is coming. I think the first thing that we are working on is to ensure that, first of all, we can secure those doses that have already been pledged. That's what we are doing. We are working with the government of DRC to secure the 3 million doses that were promised by the Japanese. As I just said, we have already the 1.5 million. There were already 50,000 doses that arrived already, and now we have 1.5 million arriving today and tomorrow. That shows that, on that front, I think the DRC will have enough, at least for the current vaccination plan. But we are also working with other partners as well through the Global Supply Working Group, but also the Vaccine Operation Group, to mobilize more partners to give more. I think we had the promises, of the US that we are also pursuing. But now we are also really supporting, working with Gavi to see if through the First Response Fund, it is possible for Gavi to also make an allocation. And already some of the signals show that that also might be the case, in the near future, to support countries like Sierra Leone that also need vaccines urgently. But now, apart from that, we don't have funding as Africa CDC now, or even that we can mobilize to buy vaccines at that cost. We are also thinking about the long-term strategy. That's the reason why Africa CDC has already been working with Bavarian Nordic, who is the manufacturer of the current Mpox vaccine that we are using, to also negotiate the possibility of transferring the technology to African manufacturers in a way that can allow us to produce those vaccines on the continent at a cheaper price. That is not the solution for today. The solution today is to mobilize the international solidarity to receive those donations and also partners that can buy for us. But we are positioning ourselves on the contribution of Africa CDC and the continent for the future. I think that's the way we have positioned ourselves. But at the same time, we also recognize that vaccination is just one of the interventions in the package of interventions that are being recommended for Mpox. That's the reason why we really push very much surveillance, so that we can identify these people early and isolate them to stop the chain of transmission. We are pushing on the IPC that I just presented for Sierra Leone. As you see, we are really pushing our health workers, our community health workers, to also work with communities to also improve all the measures that help us really prevent the acquisition of this disease. And then the second question is about what we do about cholera in South Sudan in particular. This time, I think we've learned lessons from Mpox. In Mpox, we responded well because we did not go country by country in isolation, but we thought of putting a unified continental response that then can look at the needs of each of the countries and then provide that in a way that is more sustained, but at the same time create also some of the cross-border collaboration, exchange, intervention, to put the countries together, in a much more effective way. I think that's what we are doing this time. As I said, we had requests from South Sudan, we have requests from Angola, we have requests from DRC, that instead of doing that, we are developing a call to action, continental, and we'll come with a continental plan. And in each of those countries, we provide the necessary support. What support do we provide to the countries? We provide support on capacity development. We provide the human resources, epidemiologists and so on. We also provide the needed supply, and we provide the funding, to support interventions at country level. South Sudan will benefit from all those interventions, but before, we first wanted to have a continental plan so that we organize ourselves how we support South Sudan, Angola, Sudan, DRC, and the other 16 countries that are also affected, all of them waiting for support from Africa CDC. Over to you, Director.
Thank you, Dr. Ngashi. Let's take the next two questions. The first one is on the DRC. DRC is the only country where the Mpox vaccine has been cleared for children. What does this mean for the rest of the affected countries where this kind of clearance has not happened? That's the first question. And then the second one is about the pandemic treaty signed at the World Health Assembly. The question is, in what direct ways would this treaty benefit Africa? And what is Africa CDC's official position on this? Over to you, Dr. Ngashi.
Yes, thank you very much, Director, for those questions from colleagues. I think on the first question about what happened to the other countries, we have already initiated a process in at least 14 other countries outside Africa CDC with the National Immunization Advisory Group, Technical Advisory Group, to also get an approval locally, an emergency use authorization to then apply these vaccines also in children below 18. DRC was just the very first country that moved in that direction, but we are also doing the same effort, especially in those countries that we see children are making a big proportion of those that are being affected through this outbreak. On the pandemic fund, very interesting to say that, first of all, Africa CDC has played a major role to ensure that Africans speak with a common voice. As you remember, we sent a technical team that went to sit in Geneva with the African negotiators. We convened continental meetings here in Addis with our health ministers. There were more than 40 countries that were represented here, where we really discuss as Africans to understand that on the things that we wanted around One Health, around the health financing, around the pathogen access and benefit sharing, that as a continent, we cannot just expect ourselves to get everything that we want. It was a global negotiation that brought all the continent together. We were able to secure that common position here. And then our negotiators left Addis with a clear understanding of what the continent is ready to accept and what the continent is not ready to accept. We are happy to say that this time, what we wanted on the One Health has been addressed, on financing has been addressed, in many areas have been addressed in the agreement that was just agreed in Geneva. The only thing that is left, it is the PABs, which is the pathogen access and benefit sharing. That is where we still have work to do. There are a number of things that we wanted to ensure that for every single pathogen that we provide as Africans, we contribute. And medical countermeasures are developed, whether it is a vaccine or it is a test to diagnose it or a medication to treat it, that we wanted really us to get our own share. We had really requested to get 20% of that donated for free. But what has come in if you read the annex, in the current document, you find that the principle of 20% has been accepted, only that instead of 20% for free, it is 10% for free and another 10% at preferential price. I think for us, it is that annex which is still really to be negotiated. I think many of the things that we wanted to get on that is still to be negotiated. But the good news is that we have 1 year until the next World Health Assembly in 2026 to also get that annex on pathogen access and benefit sharing also adopted. That gives us enough time really to just continue along the same lines, negotiating until we secure the maximum that we can secure for our continent.
Thank you, Dr. Ngashi. We have, I think, 2 more questions here. We have one on I think that was answered. So we have one on the rapid testing methods that are used to detect and treat Mpox. The question is, a few weeks ago, you mentioned the use of rapid testing methods to improve detection and treatment for Mpox and the related diseases like measles. How is this assisting the fight against Mpox? That's the first question. And then the other one is on the IMST. Are we likely to see the Mpox IMST also being used to fight cholera? And what would it take for this to happen? Over to you.
Yes, thank you very much for those questions. I think on the rapid test, just to say that we do have already a rapid test that has been verified by Professor Muyembe's team in Kinshasa and confirmed with a very good performance in terms of sensitivity and specificity. Now, the test is going through the other layer because Africa CDC has established what is called the Diagnostic Advisory Committee, which then has to review the result of the performance assessment that is carried out and then make a recommendation. I think we are moving in that direction. It's already here. It's about 1 month now that it is going through the processes that should move much faster. The difference it makes is that you know that one of the major challenges that is faced is the transportation of specimens, you know, from the district where these cases, where the testing is taking place. As you know, there's cost involved. In Uganda and DRC, it is USAID that provided that support. With the freeze in funding, you saw the impact that had on those two countries. Now, rapid tests come as a response because as a response, first of all, to fill that gap, and also important because the diagnostic will be done immediately at the lower level, at the level of the health center. Once confirmed, then already the isolation can take place and then shorten the time that that patient is exposing members of the family. I think it is extremely important for us to stop the chain of transmission. That's why we consider that for those areas that have got no access to testing, where the road infrastructure and transportation of samples is complex, I think rapid tests are an answer to them. Now we are in the process just to say that the next outbreak, if it happens, God forbid, I think we'll be in much better position than we have been this time because we'll have both the GenX part, the PCR testing, and also the rapid test. Now, on the question about the IMST and cholera outbreak, it is really our expectation that we need a continental response. That's the recommendation that we are expecting from our ministers and also our president, so that it can also mount a continental response that is very well coordinated with WHO, Africa CDC working hand in hand with all the other partners, as we saw last time, 28 partners coming together both at continental and at country level with one single resource mobilization strategy and working together to mobilize the vaccines that are needed for cholera. I think we really see that this is the natural evolution of the IMSC concept. It was tested for Mpox. Now it is time to also build on those good practices to expand it to other outbreaks. Over to you, Director.
Thank you, Dr. Ngashi. And with that, we have come to the end of the briefing this week. I'll hand it back to you for your closing remarks.
Yes. No, first of all, I'd like to thank all the participants for making the time again to listen to us today, and also for all those questions. Some of them also guide us in the response and also in the way that we are managing outbreaks, not only Mpox, but also other outbreaks on the continent. This time is kind of unique because it is a time that we are seeing really the decline in ODA globally, which pushes us for really greater focus on results, greater focus on efficiency, and greater focus also on sustainability, so that we start investing in a way that does not require us to go back and reinvest in the same thing. As we have seen, we had Ebola, we had COVID, but today we are investing in the same thing as if we never invested before. This is a new time. We are very much aware of that, and we are also working very hard. We have a strategy that we've been disseminating to also find an African solution to this problem. But for us, what is important is not the future of Mpox. We look forward to receiving the recommendation from the Africa CDC Emergency Consultative Group and also the WHO Emergency Advisory Group, whether they are going to lift the outbreak or not. But the reality is that there is still more work to be done, and we count on all of you really to take the message out as we continue to mobilize more support for the continental Mpox response in Africa. With that, I would like to say once again, thank you very much, and I look forward to seeing you again next week on the same day, same time for our next press conference.